Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar that is on a very important topic, that is clonal hematopoiesis, the silent driver of aging and disease. And that is a very important topic, and which we need someone who is expert, and we need someone who can understand the things very well for all the participant audience. So, with great honor, I would like to welcome the speaker for this webinar. He is none other than Dr. Prantar Chakrabarti sir, and let me share some of the achievement of sir. Sir is ex-professor and HOD of Hematology, NRS Medical College, Kolkata, and he is consultant hematologist Zoho Corporation, Tenkaski. And without any further delay, sir, the stage is yours. You can proceed from here.
Yeah, so just a moment. Hi, everyone. It's always a pleasure to discuss with you and learn from each other. So, I'm just going to. I think you can see clonal
Yes, sir, it's clearly
hematopoiesis on a
visible.
speedometer, right? So, what is clonal hematopoiesis and why are we calling it the silent driver of aging and disease? So, let me start off with a patient. A 73-year-old man who is an emeritus professor of oncology at a major medical school, okay, read several papers about clonal hematopoiesis because it's the in thing now, and asked his primary care physician to test him for chip. Now you'll see what is this chip. I'll discuss it. So patient had a normal complete blood count other than a slightly abnormal RDW, which was 15.3%. The primary care physician, being a junior one, deferred to the oncologist's perceived broader knowledge base and ordered a gene sequencing panel for common chip associated genes. These are already available in most of the developed countries, and now it is available in India also. And then, lo and behold, a DNMT3A P.R882H mutation was detected with a variant allele frequency of 7%. Now, let me tell you, according to the current guidelines, anything above 2 is considered to be significant. So, this variant allele frequency was significant. Then you'll think, well, what is this? What is CHIP, right? So, CHIP is basically an acronym of clonal hematopoiesis of indeterminate potential, right? Those of you who know also, in myeloma, we have an intermediate stage where we say MGUS, monoclonal gammopathy of undetermined significance. So this is clonal hematopoiesis of indeterminate potential. But this is not the only thing we use, right? So there is something called CHUD, means clonal hematopoiesis with unknown driver, right? So if it's a known driver, then you can call it chip. If it's an unknown driver, it becomes CHUD. And then you have something called ARCH. Again, CH means clonal hematopoiesis. What does AR mean? Not aortic regurgitation. It means age related clonal hematopoiesis, right? And then you have something called CICUS, clonal cytopenia of undetermined significance. So now cytopenia is coming in. You have ICUS, okay, and you have a number of these terms, which I will explain one by one. So what is clonal? Clonal hematopoiesis. Basically we were taught during our undergraduate days that clonal means that they've all come from the same cell, so there's a chance of them being malignant. Now, age related clonal hematopoiesis, you have to understand that as people age, their tissues accumulate an increasing number of somatic mutations, right? While most of these mutations are of little or no functional consequence, mutation may arise that can give a fitness advantage to the cell. So, when the cell becomes mutated, it was something like this, and it became something like this gets a survival advantage. And then this overtakes the other cells. When this process happens in the hematopoietic system, a substantial proportion of the circulating blood cells may derive from a single mutated stem cell. So it happens in all cells, but if it is a mutation in a stem cell, then all the circulating blood cells would eventually be affected. Okay? So this outgrowth of mutated cells is called clonal hematopoiesis and is highly prevalent in the elderly population. So it is related to age. Now you have to remember that there is one protein coding mutation every 10 years per hematopoietic stem cell. So there are around 50,000 to 2 lakh hematopoietic stem cell per person. And every 10 years, one cell is being mutated, right? There are a number of mutations. I'll discuss them again. So what could be the total number? So by age 70, an average person will harbor 3.5 to 14 lakh protein coding mutations in his or her HSC pool, right? If you calculate this every 10 years, one, this is the total number. So simple mathematics, it comes to this. So the question that always arises is age the only cause, or are there other contributing factors? Smoking definitely adds to this. That's why smoking is harmful. Cancer therapy, be it radiotherapy or chemotherapy, adds to it. Metabolic disease, metabolic syndrome, like diabetes, atherosclerosis, they also contribute to this. Inflammation, right? So now we call it inflammaging. So aging plus inflammation, we call it inflammaging. Unique environmental exposure. So right from our mother's womb, we are exposed to so many internal and external exposures in terms of the food we take, the air we breathe, the liquids we drink. And there are certain even germline variants. Remember, these mutations usually occur in somatic cells, but there are germline variants. So what happens is, in an adult, there are ways by which the hematopoietic stem cell, they self renew, and then there are certain controllers of this, right? CXCL2, CXCL2 SCF, CXCL4, TGF beta 1, and then these hematopoietic stem cells actually renew themselves, and clearance occurs to the dark subset, and they usually live in the endosteal niche. Now, what happens with age? So many phenomena occur. Inflammaging, I've already described. Senescence and decreasing support of the plasma cells. Deficient clearance of the neutrophils. Here, the clearance was occurring. Now, they do not occur. And because of interleukin 1 and interleukin 1 beta specifically, there is megakaryocytic skewing. So, there are more megakaryocytes now. Vascular leakiness is there. And then what happens is there is a positive selection of myeloid biased hematopoietic stem cells. And this can lead to neuropathy, this can lead to arterial attrition, this can lead to bone and niche remodeling, adipogenic differentiation due to increased rankle, decreased opalescence, and there is senescence of the mesenchymal stem cells. So ultimately, because of all this phenomena, what do we get? You get chip, right? Sorry, just a second. You get chip, and the major mutations are DNMT3A and TET2. They lead to leakage, perivascular permeability, altered NK cell, immune modulation, increased blood vessels, which can happen in diabetes also. Clonal advantage, there are inflammatory signatures, and there is osteoclastogenesis leading to osteoporosis. T cells also play a role here, NK cells also play a role here, especially Treg cells play a role here. So this is what goes on within the bone marrow. So how do I explain it in simple terms? At birth, there is a significant balance between myeloid and lymphoid potential, right? See, most of them are 50-50, 50-50, 50-50, 50-50. As middle age comes in, hematopoietic stem cells get depleted because of DNA damage, telomere attrition. You know, telomere maintains their life, and epigenetic dysregulation. So, some of the cells are gone, some of the cells become senescent, like this one, and the problem is that there is a myeloid bias. With advanced age, the number of senescent cells increase, and NLRP3 mediated inflammasome activation is there, which leads to enhanced interleukin 1b secretion, leading to atherosclerosis. So you might think, okay, these are happening in the hematopoietic stem cells, so maybe the blood cells will be affected. Unfortunately, most of the cells in the body are affected, and I'll show you the cardiological effects of this age related clonal hematopoiesis. Now, if you use intensive chemotherapy, they lead to TP53 mutations, there's T cell mediated destruction. Even during autoimmunity, there can be immune evasion, which is PIGA mediated, or myeloid malignancy mutations due to DNMT3A, ASXL1, mainly these two, leads to clonal evolution, ultimately MDS or acute myeloid leukemia. But this is only part of the story. As I told you, it is not only in the blood cells. When we are young, there are no somatic mutations. There is normal blood count. Low frequency mutations start, they get selected, you do an NGS, and look at this. Development of hematological malignancies is 10 times. Cardiovascular complications, right? Because these stem cells also lead to other cells. 2 times risk of cardiovascular complications. What are the complications? I'll discuss later. So, with age, what happens? Which is the commonest mutation? DNMT3A, as you can see here. Okay, DNMT3A. This is the commonest, except when you have elevated cholesterol, the commonest is TET2. Another significant mutation is found when you use cancer therapy, and that is, we all know, TP53, right? So, depending on where they are, what age they are, what kind of inflammation they have faced, the mutations vary. But you have to remember that once they are mutated, they have a proliferative advantage, and mediated by DNMT3A TET2 epigenetic changes, there's enhanced expression of interleukin 6, interleukin 1b, and NLRP3 inflammasome. So there is a pro-inflammatory T cell polarization. The entire body is being skewed towards inflammasome. Increased net formation, neutrophil trap, and enhanced thrombogenesis. So now we have understood that behind atherosclerosis, we used to say, no, there's a genetic predisposition. But due to inflammaging, there are this clonal hematopoiesis. If I show you within the marrow of a 70-year-old man, you can see that there are distinct differences, especially in B and C, where the common CD34 cells are decreasing and you're getting PD1, CD163, which drive the process. So, as you are exposed during lifetime to infections, you get all sorts of mutations. There's a selective advantage and you get CHIP. So if you get CHIP, it becomes something which has a higher risk of developing a overt hematologic malignancy. And who actually helps that? So that also is a criminal, is inflammation. That's why, you're now talking of anti-inflammatory diets, less stress, because these can all lead to the complications. So there are some sex differences. As I told you, there is sometimes some germline risks also, genotoxins, especially smoking, irradiation, chemotherapy. As the adults cross 50, whatever was low abundance called microchip now becomes VAF more than 2%. Remember the emeritus professor? His percentage was 7%, right? So, now what are the malignant outcomes? Myeloid clonal hematopoiesis, CHIP, SICAS, and then MDS, CMML, AML, ET, PV, polycythemia vera, myelofibrosis, Philadelphia negative CML. And if you have a lymphoid CH, so I told you that there is a bias towards myeloid, but lymphoid clonal hematopoiesis can also occur, and this leads to CLL, small cell lymphomas mainly, and this can have a gradual progression. But non malignant outcomes, cardiovascular disease, including coronary artery disease, heart attacks, ischemic heart failure, stroke, COPD, chronic kidney disease, rheumatoid arthritis, osteoporosis. I told you about osteoclastic increased activity and thrombosis. The only thing clonal hematopoiesis with age can decrease the possibilities Alzheimer's dementia. So it's not all bad, but most of it is bad, right? And you have to understand that even coronary artery disease has a clonal background. So if I look at clonality and I rise through this pyramid, first you will have clonal hematopoiesis, which can be age related. Then you can have CHIP. Then you start having cytopenia. So, clonal cytopenia of undetermined significance. You can have dysplasia. You can have single cell. And then you can have MDS or AML, which is an overt malignancy, right? So, this is how it happens. If there's more dysplasia, it is MDS. Now, what is reflected in the peripheral blood cell counts? In CHIP, the cell counts can even be normal, right? But if there is dysplasia, there can also be cytopenia, and sickness is between dysplasia on one side and clonality on the other side. So, if you have an unexplained cytopenia, always remember sickness. How do you differentiate? So, let us look at what is the definition of CHIP. Presence of at least one somatic mutation that is relevant clinically. Okay, it has to be relevant clinically, otherwise found in myelodysplastic syndrome or other myeloid neoplasms. Absence of persistent cytopenia. Why? Because if there is presence of cytopenia, it goes into sickness. And exclusion of MDS and all other hematopoietic neoplasms. So even CLL, MDS, you have to rule them out. Then you call it CHIP. Okay. Then, idiopathic cytopenia of undetermined significance. Idiopathic means no clonality. Okay. So, if there is clonality, it is sickness. If there is no clonality, it is idiotic for us, pathetic for the patient. Presence of relevant cytopenia in one or more lineage for at least 6 months. It cannot be explained by any other disease, but you do not even detect mutations. So, diagnostic criteria of myeloid neoplasm also obviously is not fulfilled. Diagnosis of exclusion. But if there is clonality, then it's sickness again. Here it is not 6 months, it is 4 or more months in one or more peripheral blood lineages. Diagnostic criteria of myeloid neoplasm should not be fulfilled, and exclusion of all other causes of cytopenia, because essentially, as I told you, it is a diagnosis of exclusion. So, CHIP versus sickness. For diagnosis of CHIP, the current cutoff is, as I told you, 2%. But there are some groups, and this is one group of Gondek et al., who say they want to apply a cutoff of more than 20% of the dominant clone, because otherwise we are diagnosing too much of CHIP. But even if 2% is detected, you have to follow them up. Now the question is, how do you detect the clone? What is the technology? So, we have first generation technology, second generation technology, where we do library preparation, DNA fragmentation, and cyclic array amplification like pyrosequencing, Solexa, Illumina platform. And then third generation, you have Pacific Biosciences looking at tunnel emission spectra and Oxford Nanopore, which is cheaper. You also have IBM DNA transistor. So many platforms are there. Each has its own advantages and disadvantages. Oxford Nanopore, the yield is less, but not very less. It is 2 GB compared to Genexus, which gives you 19.2 to 24 GB per chip. 48 hours turnaround, 10 to 1000 nanogram. Error rate is 12%. Genexus is less than 1%, but cost of instrument is only $750,000. I'm telling only, but I hope it comes down. So you can do targeted sequencing or you can do whole genome sequencing using NGS. Now, if at age 70 you use different technologies, if you use exome sequencing, you can detect to a sensitivity VAP of 0.01%. If you do whole exome sequencing, then it is 3% sensitivity. If you do whole genome sequencing, you'll get VAF up to more than 7% only. So anything lower than that will not be detected. So, if you look at clonal hematopoiesis and hematologic disorders, targeted has the best sensitivity and whole genome has the least, but they can be effective if you use it in context. Now, what are the factors that can affect the prevalence of detected clonal hematopoiesis? What kind of sequencing depth are you using in NGS? The set of genes you are sequencing, minimum percentage of blood cells in the mutations. If there's severe cytopenia, you might face challenges. And inclusion of controls that account for background mutation rate, because I told you sometimes there can be germline variants and sequencing artifacts. So, what you have to understand is one, the chip associated mutation is there. There's a clonal advantage and risk of blood cancer. And then there are innate immune cells which can further drive it, which associates with non-hematologic disorders like cardiac disorders. Now, which is the commonest mutation? So this is from a paper in 2020 by Siddharth Jaiswal and his team. DNMT3A is the highest, then it's STAT2, then ASXL1, PPM1D, JAK2, which is also found in myeloproliferative plasms, SF3B1, SRSF2, TP53, which is a notorious mutation, GNAS, and GNB1. So, depending on what you're looking at, you might look at targeted genes. So if it is aging associated, it might be age related or chip. You have to at least look for DNMT3A, TET2, ASXL1, JAK2, TP53. Okay. If there is a history of chemotherapy, you have to look at TP53 and PPMID. In aplastic anemia, you have to look at BCOR, BCOR-L1 mutations, PIGA mutations, and ASXL1, DNMT3A. In severe congenital neutropenia or Schwarzman, Body and Diamond syndrome, again, PP53, CSF3R. Unexplained monocytosis, you will have to look also at RUNX1 in addition to ASXL1, CBL, DNMT3A, NRAS. That's why one size does not fit all. Depending on the background, you have to be looking at the genes. So, how do you look at it? You have clonal hematopoiesis. You do not know what are the drivers. I told you they are called CHUT. You have known drivers. If VAF is less than 2%, we call them microclonal hematopoiesis. If VAF is more than 2%, then you have to see whether it's myeloid or it's lymphoid. So if it's myeloid, it can be CHIP, it can be SICAS, it can be myeloid MCA or ambiguous MCA. In lymphoid, you can have L-CHIP, lymphoid MCA, and obviously ambiguous, which is there in both groups. These are all for terminology's sake. But what will you do? What will happen to these patients? Hematological effects, extra hematological effects. Hematological, deep vein thrombosis, myelodysplastic syndrome, acute myeloid leukemia, lymphomas. Non-hematological, cardiovascular disease, atherosclerotic cardiovascular disease, heart failure with preserved ejection fraction, non-ischemic ejection fraction, high fraction ejection, COPD, type 2 diabetes. So there have been certain studies, but these are very small numbers. Hematologic malignancy, they picked up 16, of which 31% showed pre-existing clonal hematopoiesis. They picked up 37 patients, did a whole exome. As I told you, whole exome has a higher sensitivity than whole genome. They picked up 42%. SNP arrays, they have picked up 14%. So, what happens to the person, or say, what happens to a clonal hematopoietic rat? In 2014, we knew that it is associated with increased all-cause mortality, cardiovascular disease. In 2017, we established it as a cause of atherosclerosis. In 2021, DNMT3 and TET2 mutations were associated with a worse prognosis in high ejection fraction heart failure. DNMT3, a deficient myeloid cells, showed NLRP3. So clonal hematopoiesis in 2022 has predicted heart failure onset below age of 65 years, worse outcome in cardiogenic shock, irrespective of the etiology, be it ischemic or non-ischemic. And these mutations have been observed in the brain, COPD, hematologic malignancies, type 2 diabetes. I have talked of mortality in ischemic heart failure. Now, what do you tell your patient, like that emeritus professor, right? I have given you some examples from different CHIP clinics nowadays. Where do the patients come in? Suppose you are doing germline DNA testing and you detected certain somatic mutations. You picked up hematopoietic mutations when we are looking for non-myeloid neoplasms like lung cancer. Non-neoplastic conditions, cardiovascular events, you saw certain arrhythmias, you were picking up mutations, you pick up CHIP. Blood count abnormality, but no specific diagnosis. This is what hematologists will see more. And then there are some healthy persons who are getting anxious and getting tests done. Now, most important is you have to explain the condition and the patient specific risks. You have to customize the diagnostic testing recommendation, individualize monitoring plan, and whom they should visit: cardiologist for cardiovascular risk assessment, medical geneticist, social worker for counseling, financial counselor, because the insurance companies might tell you we will not pay. This is a genetic disease. And in future, maybe other medical specialists. So if you tell me, okay, you have given us a lot of knowledge, how do we look at this other than in healthy persons? If you get a person with peripheral blood cytopenia, rule out nutritional deficiencies, drugs, immune mediated, other diseases, other malignancies. If you find something, treat it. If you don't find something, look at whether there is dysplasia more than 5%. And then that can be a myeloid neoplasm. If there is no dysplasia, you do cytogenetics, FISH or SNP arrays, it can be a myeloid neoplasm if the blasts are increased in peripheral blood. If nothing is there, then you go on to do a next generation sequencing. You do not find anything, cytopenia persists, ECAS, you find something, variant allele is at least more than 2%, some are saying 20%, it's SICAS. Hope you have understood it. How does the NIH monitor CH? By blood and urine samples, heart activity monitoring testing at a regular interval, ultrasound of neck arteries, liver heart scan, bone mineral density scan, lung function tests, cheap swab or skin punch biopsy to look at the mutations. So they say you have to do bone marrow and peripheral blood counts twice a year. Impossible in our country, patient won't agree, but at least once a year is reasonable. NGS testing also once a year for symptomatic patients. If they're not symptomatic, just follow them up. So bone marrow, peripheral blood counts twice a year, diagnostic criteria not filled, NGS once a year, further testing non-required in asymptomatic people. Now there is a clonal hematopoiesis risk score, right? So if you have, say, more than 2 mutation number, VAF, then you get a high score. If red cell distribution it is more than 15, so RDW is so important. The score is 2.5. If MCV is more than 100, we say with age, okay, B12 deficiency. If you can't find it, it gives you a score of 2.5. So this is how you re-stratify clonal hematopoiesis. This is how the groups separate, right? No chip SICUS, then chip. Worst is SICUS. And then single DNMT3A versus other mutations show a higher incidence of myeloid neoplasms. So, using this CHRS, you can classify them into high risk, intermediate risk, low risk. So, another important thing is what happens due to age. Mutations come, right? But depending on whether you have given chemotherapy or radiation, whether you are a male, you have a germline predisposition, or you're smoking, smoking leads directly to increased ASXL1, which is a marker for AML mutations. So chronic liver disease, chronic kidney disease, COPD, osteoporosis, blood clot, hematologic cancers, right? And only decreased risk is Alzheimer. So what happened to a knowledgeable patient as I come to the end of my discussion? The emeritus professor who had a DNMT3A mutation with a significant VAF has struggled with fears about his future. He has advised several of his colleagues not to undergo genetic testing, saying sometimes it is better not to know. Nothing has happened to him, but he believes every day that he'll die due to blood cancer. So you can use this data. There's a chrs.app.com. You can convert them into high risk, intermediate risk, low risk. In the intermediate risk, the 10-year risk of myeloid malignancy is 7 to 8%. In the high risk, it goes to above 50%. So in this group, you should do CBC and differential count every 3 months. Repeat NGS annually. Repeat bone marrow and clinical changes. Consider risk benefit of clinical trial participation. So we always say, whatever we see in medical science is the tip of the iceberg. What I discussed with you was tip of the iceberg. This is what clonal hematopoiesis is. Hope that I've been able to discuss and make you understand what chip is. So I'll stop sharing and come back to the show.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions, sir. With all your permission, shall we take these questions one by one?
Yeah. Please.
The first question I can see from Dr. Subramaniam, and he is asking it
Mhm.
is related to. Let me, sir, is getting loaded. Just a
Yeah.
second.
Mhm.
The first question I can see from Dr. Subramaniam, he is asking, should clinician screen for CHIP and in elderly patient or those who with unexplained cytopenias? Can you please share some point on that?
Yeah, obviously, as I told you, unexplained cytopenia, you rule out nutritional causes, you rule out other causes, they should be screened, right? And there are certain chip panels now which are available, which only look at those mutations which are at a higher point. So, obviously, if you have unexplained cytopenia, you should screen. Yes.
Thank you so much for sharing your insight on that question. Moving forward, we have another question from Dr. Dheeraj Chauhan, and he is asking, how can the presence of CHIP influence risk stratification in patient undergoing chemotherapy or stem cell transplant? Could you please share expertise on that, sir?
See, when we are doing a stem cell transplant or chemotherapy, we are trying to get rid of the cancer. At that time, chip does not matter. Some of these mutations are also present in myeloid neoplasm. So if someone has ASXL1, we know it is bad. If someone has TP53 in a cancer, it is worse. But then we are not calling it CHIP. At that time, it's a driver mutation of that particular malignancy. Remember, CHIP is when we are detecting it in a person who does not have a hematopoietic malignancy. Sometimes they might have others, right? Lung cancer, breast cancer, and you detect this. But then you be careful. If they fall into the high risk group, as I told you, you should follow them up. And two important indicators in cytopenias, one is increased RDW and increased MCV, which can be done by any cell counter.
Thank you so much, sir, again for sharing your expertise on that question, sir. One feedback from Dr. Subramaniam. He has written very
Hmm.
well presented. Thanks for responding my question.
Thank you. Thank you. My pleasure.
Welcome, sir. And one last question I would like to sell, sir. Are there any targeted therapies or preventive strategies currently under investigation for chip associated risks, sir? Could you please share some expertise on that?
At this point of time, there are certain clinical trials, but we have not been able to do. But certain silencing RNAs are being looked into targeting these mutations, especially to prevent atherosclerotic heart disease and also to prevent heart failure with preserved ejection fraction. So as we learn more about this, I think we will see, because only watching them and they getting worse is not what we are. And we actually, in medical scientists, we have an action bias. So we will try to do something. But the most important thing is to pick them up early and to monitor them. That is what we know till now in 2025.
Thank you so much, sir, for answering this question, sir. I hope it will be very much helpful to all the participants who have joined this session, sir. Sir, as I see, I can't see any further questions, sir. I hope you have done justice to this topic and able to solve all the queries related to this topic. Sir,
Hmm.
as there is no more questions, sir, shall we conclude this session for today with all your permission?
Yeah, 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 yeah.
Thank you so much, sir, for
I think
joining.
we,
And sir, it was great honor to have you on our platform. As we know that this is a very important topic and less given importance, sir. Thank you so much, sir, for making this thing easy for the all the participants, sir. We would like to see you in future also. Till then, take care of yourself. Thank you so much, sir.
yeah. Thank you. Thank you.
Bye, sir.